My name is Steve Aragon. I'm delighted to be here and hope that what I have to present is interesting and useful. The title of my research is The Latent Structure Provider Patient-Centeredness and Its Effects on Patients' Experience of Care. And first and foremost, I'd like to acknowledge Dr. Debs and her Winston-Salem State University Center for Applied Data Science for supporting economically my research. This research has 5 primary goals. First and foremost is to illuminate the structure of patient-centeredness and its significant influence on patients' experience of care, particularly diverse and economically disadvantaged patients. Secondly, to advance the primary provider theory as a new standard with the potential to prevent health disparities and improve quality. Third, to increase diversity in patient-centeredness research through the training of diverse graduate research assistants, which we've been very successful at for the first 2 years, and I'll present some of their research during this study or during this presentation. Lastly, to develop and implement an applied data analytics patient-centeredness measurement class for MHA graduate students. That's been accomplished. And fifth, to demonstrate the usefulness of structural equation modeling as an applied data analytics approach for informing causality. All the research is guided by the primary provider theory, which is a generalizable theory of how patient-centeredness of doctors, nurses, phlebotomists, radiology technologists, dentists, et cetera, all healthcare providers influences patients' experience of care and other outcomes. For your information, patient-centeredness is the underlying ability of healthcare providers that affects the quality of their interaction with patients during patient encounters, and therefore their overall experience of care. The most important tenet of the principles of the theory hold that it is the foremost ethical duty of healthcare providers to always protect the best interests of their patients above all else. Here's a model of the theory. The lines, the arrow, single-headed arrows indicate directed relationships among these variables. As you can see, there's a direct relationship or direct effect from patient-centeredness of providers to patients' experience of care, mediated by the patient-centeredness of the provider's associates and the patient-centeredness of waiting time. These are the key constructs in most healthcare experiences or encounters. Now I'm going to go very rapidly, and I'm delighted to present the research of one of my graduate research assistants, Tonya Mcginnis. She looked at the effects of patient-centered physician behaviors on minority and economically disadvantaged female patients' experience of care in clinics. Her research considered a sample of 744 minority and poor female clinic patients. It employed multiple regression, t-tests, F-test, and analysis of variance. The physician behaviors considered are in the first column: friendliness, concern, participative decision-making, and informativeness. All these had positive effects on the patients, and they were all significant. The model explains 53% of the variance of patients' experience of care, and she developed a model for predicting African-American female patients' experience of care from this research, and I'm not going to read the model, but there it is below. That model can be used to predict African American female patients' experience of care in clinics. She also happened to be involved with a case study and wanted to integrate it as a comparison with her results. This case involved following a compound fracture and surgery, a 33-year-old African-American male. So we've got a male compared to females who presented to the emergency department with a swollen right ankle and pain. The physician's friendliness, concern, participative decision, and informativeness on a scale of 1 to 5 were assessed. The physician scored a 1, a very poor. The physician did not establish trust with the patient or the family. The physician did not address the patient's concerns, questions, or manage the patient's pains. As a result, the patient requested a different physician. The hospital provided one who was more patient-centered, and the concerns were addressed. Conclusions of our study are that these behaviors of friendliness, concern, participative decision-making are positive behaviors that have positive effects on the patient's experience of care. These results were consistent with the primary provider theory's hypotheses. The next one is another graduate, a new graduate assistant, Vanessa Sanabria, who looked at the effects of patient-centered physician behaviors also on Hispanic patients' experience of care. This involved a sample of 323 Hispanic patients. Looked at, again, concern, informativeness, friendliness, and skillfulness. Friendliness, as you can see, and as far as column 2, the effect was negative. So this sample of 323 Hispanic patients didn't perceive their doctors to be very friendly. 3 of these variables did not have significant effects: informativeness, friendliness, and skillfulness. Concern did. She ran a second regression with concern, and you can see the effect of concern is 0.63. She likewise developed a model for predicting Hispanic patients' experience of care based on their scoring of concern, and there it is in the blue rectangle. The last graduate research assistant study looked at the effects of nursing behaviors, not physicians. These studies cover a range of providers, nurses, and doctors in this presentation across various patient populations. Population here is African American male cardiology patients. Here are this included 271 African American male cardiology patients, and there were 2 significant effects: the promptness and informativeness of nurses. Their attitude and attitude had a small effect, which by all intents and purposes, you would hope that it would have a much larger effect.
You have about 3 minutes left.
Okay, thank you. My screen is not advancing.
Click back on your slide.
Thank
or
you.
on the side where all the lift, there you go.
She reran the model using promptness and performance, and she likewise produced a predictive model. This last one is a study that was published during the year. What we see when you look at the literature, there are several counterfactuals of patient-centeredness. I call them counterfactuals because in my experience, they are counter to facts. Some hold that the quality of physician-patient communication is due solely to the education and language competence of patients. That is, it has nothing to do with the physician or the provider. Secondly, the benefit of shared decision-making has been challenged in some research, and albeit this research was in 2018, and that family values and preferences should be excluded, amazingly, from decision-making in pediatric intensive care units. The importance of physician personality on patients' experience of care has also been questioned, and the value of transparency and giving patients access to their medical records has been questioned. And lastly, the requirements of patient-centered care have been deemed to be excessively burdensome when they appear inconvenient or challenging. So in light of these counterfactuals of patient-centeredness, we conducted a study to challenge in emergency departments, to challenge the proposition that provider patient-centeredness affects patients' experience of care mediated by waiting time across 2 national random samples and 5,000 bootstrap samples. The results, evidence converged, unanimously supporting the model proposition that provider patient-centeredness positively influences emergency department patients' experience of care, including the patient's likelihood to recommend the emergency department and hospital and their overall ratings of care. Evidence supported the model's goodness of fit, its measurement and variance across both samples and across the means and standard errors and confidence intervals of 5,000 bootstrap samples. Evidence supported the model's plausibility when it was compared to a competing model, and the model was coherent with the hypotheses of the primary provider theory. Here are the final standardized results. Physician patient-centeredness affected the patient-centeredness of waiting by 0.79. These are all significant effects. The patient's experience of care effect was 0.8. The likelihood of recommending was 0.765, and the patient's overall ratings of care were 0.77. The model explained 81% of the variance of patients' experience of care. So that brings me to the end. I hope I met my timetable, and I want to thank you. And now I'll be happy and delighted to answer any questions anyone may have.
Thank you, Dr. Aragon. Thank you so much. It was great to see that your study has been applied to those subgroups. Those are very interesting. Just not to see the subgroup results, but the comparison between them as well. So it's a great work. Any question? It probably is going to have only 1 minute for question, only probably one question, and then we're going to move ahead with our interactive quiz number 2.
If anyone would like to follow up with questions, my email is provided on this slide.